How about now?
It's the full screen now. Thank you.
Okay, we'll get started, or should we wait? Or
Oh, the floor is yours. Anytime you'd like to start, that'll be excellent. Thank you.
okay. So this topic is not, nobody needs an introduction in terms of what COVID is, right? So we're all dealing with these for quite some time. Sorry, I don't have any video on me, so it's all going to be audio. So it started sometimes in December when city of Wuhan and in China, they started noticing something is going on infection-wise, and they got suspicious that this could be a new outbreak that they had in 2003 and before that, also known as severe respiratory syndrome. And eventually, the cases started to get noticed more and more, and they thought that this is not just typical simple virus, and this is replicating much faster rate and affecting a lot of people with high infectivity rate. And eventually, they declared that this is going to be some sort of an endemic in that country. But then, as time went on, we learned that this is actually a pandemic. And sometimes in March, WHO said, okay, this is a worldwide pandemic, and today where we are, and we're still fighting it. This is almost September, and we're still fighting it. So it's an ongoing battle for almost 9 months. Now, about a month ago, when it really peaked, so on the left side, you're seeing active cases. Now you see bigger the circle, more cases we have. So obviously the whole United States is full of these big circles. Countries like India, Europe, Brazil, Mexico too, they are very hot spots right now. And these are the fatality rate. So unfortunately, we have experienced very high fatality. The highest we know is coming in from Italian data earlier in the disease stage, pandemic stage, but Mexico is also pretty high up there. So it is, no needless to say, this is very, condition that's very life-threatening. Now, I'm going to focus obviously on heart issues and heart patients. So we looked at all, so the scientists have looked at patients with COVID, and this is basically March or April data. And what they found is, what is the most common condition they have? We don't know it's a cause and effect, but it is more like association. So people with cancer, they have about 5 to 6% mortality rate. Then hypertension is about 6%, chronic lung disease about 6%, diabetes about 6 to 7%. Now, heart disease is up to 10%. So people who were diagnosed with COVID, up to 10% of people had heart disease. Also, majority of like 40% of patients who were diagnosed with COVID and they're hospitalized, 40% of them are suffered either cardiovascular event or stroke event, some sort. 9% develop shock, meaning they don't have enough blood pressure to provide nutrition to the body, and 4% develop severe acute kidney injury. So let's talk about the virus. How does it, what's going on? What do we know about the virus so far? So this is coronavirus, and it has its own DNA, RNA, and some proteins. These are the spike proteins you may have heard in the news. So there are receptors on our body cells. They attach to our body cells, and they get internalized. The process is called endocytosis. The virus is pretty smart. It brought its own sort of assembly and mechanism, but they use our machines, that's in our cells called ribosome. Then they replicate their genome using our machines, and they replicate the proteins. And once we make their own protein in our cells, it's just a factory. It's overproduction, basically. Now they make the essential components. All of these turns into gene, and gene becomes protein, and they become more viruses, and they just leave our body and infect more cells of our body, and they become part of our respiratory tract, and we just aerosolize them and spread the virus. Now, it causes a lot of havoc in the body, but specifically the heart. So there are four mechanisms by which it can do these things. First is microvasculature. So what I mean by that, so our cells, blood vessels, have endothelium cells. Those are single cells that make up our capillaries. And they have pericytes, which are nutrition providing cells to the endothelial cells. So this is basically the pericytes are basically they feed our blood vessels nutrition. So the blood, they remain intact. Now the virus affects both directly endothelial cells and cause damage, and pericytes. So it's double damage because they cannot recover. Now we know that when you have microvessel dysfunction, it can cause heart issues, specifically heart attack. Second mechanism is macrovascular, such as like coronary artery disease. So what it does, it's the cells directly damage the endothelial cell of the coronary arteries and cause myocardial infarction, like heart attack. Okay. Now, third mechanism is it causes inflammation and causes cytokine storms. What I mean by that, cytokine storm is every time we have infection or some sort of a sickness, our body sends signal to rest of the organs, say, hey, by the way, we're being attacked, there's an infection, there's an injury, wound, something, and it sends all these signals and cause this cytokine release, and this is a messenger, basically. Now the cytokine storms, it increases more inflammation, it just increases the level of inflammation, and it's not good for the body, specifically if you already have a blockage or like coronary artery disease. If you already have a plaque, cholesterol built up, this cytokine storm can make it unstable, the plaque can rupture, and it causes myocardial infarction, also known as a heart attack. The cytokine also attacks the muscles, not the cytokine itself, but the lymphocytes, the T cells and other inflammatory cells. They attack the muscle of the heart and cause inflammation there too. And then eventually it can lead to heart failure. Now, fourth mechanism is the virus itself can damage the myocardium, just like the other cells. They just invade our muscle of the heart and damage it and cause myocardial infarction. We see troponin elevation. It can lead to arrhythmia and eventually heart failure. Okay. Now, you guys may know about these. So the most common tests for cardiologists are BNP, brain natriuretic peptide, and troponins. Now they mapped it out and they found that this high sensitivity CRP, which is another inflammatory marker, they found that there's no strong correlation. I mean, it is a positively correlated, meaning if the level of inflammation is higher, you will have higher rise in troponin. But you can see there's R square, which gives you the correlate how strongly correlated they are. Closer to 1 is better. So it's not that great, but still there's an upward trend. But what I'm trying to say is like troponin is not an exact substitute for inflammation and vice versa. Same thing. So they compared one biomarker of the heart with another, and they're loosely correlated in patients with COVID. So I don't think those tests, basically what I'm trying to say is either of the test is not substitute for the other. This is a busy slide, but I'll break it down for you. So let's look at the one on the left one, troponin. So patients who were admitted to the hospital, and they break down based on fatal patients, meaning those who died versus cured patient who recovered. The troponin level who at the time of admission for patient who did pass away, they had significant jump from time to admission to impeding death and hospitalization. So there was a statistical difference between these two stages of the hospitalizations. Compared to the patients who survived COVID event, their troponin level were not significant. They did not go up. So what does it tell us? So troponin can work as a prognostic marker. If it's positive and rising to significant level, it portends poor prognosis. Same thing with the pro-BNP, which we use in heart failure patients. those who died, they had a significant rise in their proBNP. Compared to those people who did not die, they had no significant change in their proBNP levels. So again, both troponin and proBNP level can serve as a prognostic marker. Now I really like this slide because it talks about how we use troponin like biomarker and history of cardiovascular disease, and how does it impact the mortality in COVID patients. So if you have history of if you have a patient with history of heart disease plus they have elevated troponin, the mortality rate is about 70%, which is pretty high. Compared to the patient who have no history of heart disease, but they have elevated troponin because of cytokine storms and damage to the endothelial cells, whatnot, the mortality is about 50% from that number, 37%. Even further, let's say you have a patient with coronary artery disease, some sort of heart disease, and they have no troponin elevation, like I showed you in the previous slide, their mortality is very low. I mean, relatively low, I should say, still 13%. And if you have neither, no troponin elevation, no heart disease, mortality is less than 10%. So what does it tell us? History of heart disease and positive biomarkers such as troponin are very, very, very important in guiding in terms of prognostication purposes. Now, those who died, what happened to them? And what kind of cardiovascular disease? So that's what we're going to talk about next. So 50% of the patients who died from coronary COVID status, they had some sort of cardiac injury. And how do we define cardiac injury? It could be myocardial infarction, like positive troponin, etc. Up to 50% also had concomitant arrhythmia. This is not to say if you have arrhythmia, you have 50% chance of dying. It is just that those who died, they had 50% of them had some sort of arrhythmia or cardiac injury. Likewise, 40% developed heart failure, and about 30% developed coronary artery disease, had a coronary artery disease. So let's talk about coronary syndrome. So I'm going to break down a few conditions in COVID patients. So myocardial infarction can happen mainly through three mechanisms. One is COVID infection has to happen. Then it creates inflammatory response. And if patients already have blocked arteries, coronary arteries, they can have ruptured plaque, and then they get type 1 myocardial infarction that we call NSTEMI or STEMI typically. Now you have COVID infection and you have, let's say, tight stenosis, meaning you have calcified coronary arteries but no plaque rupture. They can have supply-demand mismatch because they have hypoxia, pulmonary hypertension, they're sick, septic, stuff like that. They create supply-demand mismatch that causes myocardial injury, and that can lead to we call type 2 MI. When I say type 2 MI, it's called supply-demand mismatch MI. So there is no plaque rupture. It's just that coronary artery disease does not allow enough oxygen to the heart tissue, and heart tissue suffers ischemia. Third mechanism is, this is something very unique to COVID infection, but not certainly only due to COVID. You can get hypercoagulable state. What I mean by that is you have tendency to form blood clots, and the blood clots can go to macro or micro vessels, small or big vessels of the heart, and it cause almost like type 1 myocardial infarction. Okay, so this is important how we're going to treat this patient. So now, typically, COVID or no COVID, when we see patient with STEMI, acute myocardial infarction, or high risk non-acute myocardial infarction, basically unstable angina, and the troponins are very high, stuff like that, we have two options for this patient. If they live pretty close enough to cath lab, we just take them to the cath lab and treat them. In cases where they live remotely from, let's say, WVU, for example, then we ask the emergency room there to give thrombolytics and treat them. On the other side, if you have patients who have low or intermediate risk, and how do we define low to intermediate risk? You guys always help us in the community. You guys get a stress test for chest pain, and we basically, what we do is we say, okay, well, based on their degree of ischemia and abnormalities on the stress test, or CTA, cardiac CTA, which is relatively newer technology, it helps us to guide treatment, whether to take them to the cath lab, whether it's just start them on antianginals. But if they're hospitalized, we calculate something called TIMI risk score, GRACE risk score. Practically, we don't every day do it, but just we know the variables and we ask those questions that are in the scores, and we just make clinical judgment based on that. Depending on the risk, let's say if they have a very high risk, then we sort of can do the cath, but not on emergent basis. They will be hospitalized, they will be treated medically first, and a day or two later, we just put them into, we just send them to cath lab versus medical management. Now, because of COVID, obviously there's a risk of exposure to healthcare workers. Some of the, and because it can cause hypercoagulable state and blood clots, some of the experts in the early pandemic suggested, why don't we just thrombolyze everyone and not take them to the cath lab? Well, in theory, it's a great idea because that way you don't have to be exposed. You can still treat the patient the way you want to treat. But interestingly, only 60% of COVID positive patients truly have blocked arteries. 40% of them do not have blocked arteries. So what's going on here? So we don't know. We don't really know what's going on in terms of pathophysiology, but there might be thrombus that got either dissolved or they got we call stress-induced cardiomyopathy, or some sort of illness that up to 40% of patients do not have blocked arteries. So now if you don't have blockage, who are you going to thrombolyze, right? You're just taking more risk for giving blood thinner, like very potent blood thinner that can potentially cause bleeding, but they do not have a benefit because they don't have thrombus to lyse, right? So now that created some discussion among experts who've been doing a lot of randomized controlled trials and such. They were more favoring stents, and they said why. So we call TIMI 3 flow. What it means is higher the number, better the flow. So we scale from 0 to 3. 0 means no flow after we put a stent in. 3 means great flow. So in non-COVID patients, we're talking about pre-COVID era, when we give thrombolytics, we achieve perfect resolution of blood, obstruction in 50 to 60% of patients. The risk of ischemia, recurrent ischemia, is very high because you have not achieved a full revascularization. And hemorrhagic risk is about 2 to 3%. And rarely, let's say, again, going back to the example I gave you, let's say you have a patient who has ST elevations outside of the hospital, away from Ruby. We just ask them to thrombolyze these patients and send it to us, and we just observe them for the next 24 hours. Up to 5% of those people have no blockages. But now this goes to COVID era. It's even hard to achieve good resolution of flow because of hypercoagulable state and whatnot. Recurrent ischemia risk is really high because of supply-demand mismatch and pneumonia and ARDS and all that. Also, when you have cytokine storms, not only you're prothrombotic, but you're also prone to bleeding, and that can worsen in patients with COVID if you give thrombolytics. And the major point is up to 50% of patients may not have blocked arteries. So should we even think about giving fibrinolytic therapy? The issue is, like, as long as you can take care of yourself really well in terms of your good protocols in your hospital, you do not have to worry about if there's a fear that you may catch infection from possible COVID positive patients when you take them to the cath lab. But if you appropriately PP yourself, you should be okay. So current recommendation is still out there. We don't know, but a lot of people are now favoring take them to the cath lab and see if they need a stent or not. Now, obviously, what we need to do, this is a sort of a busy slide, but how can we diagnose patients with something like a myocardial infarction, or if they have a positive troponins? How do we risk stratify them without getting exposed and trying to figure out so many things at once? So So there's a proposed, so this was a case report, but what they're trying to show here is that if you do CTA, specifically cardiac CTA protocol, you can obviously looking at the chest, lungs, right? So you can rule out any significant degree of pneumonia from COVID. You can look at the coronary arteries, nicely seen. In this particular example, the patient did not have significant coronary artery disease. Also, I think that, and this is my insertion, you can also make sure that there is no aortic dissection and stuff like that too. So CT gives you a lot more information. Plus, if you modify your protocol and tweak physics of CT a little bit, you can also find whether patient have myocarditis, which is a very big topic, and I'll discuss in a lot more detail in the later slides. So obviously, this is very, very, very important. Okay, stress-induced cardiomyopathy. Now, you guys heard about Takotsubo, stress-induced cardiomyopathy, broken heart syndrome. This is very interesting study, came out from Cleveland Clinic. So what they looked at it, so obviously this is COVID era. Before COVID really got picked, the cases of stress-induced cardiomyopathy were pretty flat compared to a year before that and 2 years before that. So there was no trend, essential trend. Now what happened in COVID era, stress-induced cardiomyopathy, which means the patients present like ST elevation myocardial infarction, but they do not have no significant coronary artery disease, and the heart is not pumping well and all that good stuff. But look at what happened in COVID era. Let's say this is 2, it almost quadrupled. Interestingly, you say maybe it's because of COVID itself, but that's not the case. All of these patients were COVID negative. So what does it tell you? There's a lot of stress related, stress of catching infection, stress of dying from COVID, that creates a lot of fear in just general population. That's exactly what happened. That's the actual theory, but we know that, this is a very stressful time financially. I mean, this was published in May when stock market went down in March and April. So you can imagine this, people can go through lots of stress and it predisposes into stress-induced cardiomyopathy. So another thing, something that fascinates all of us is the number of STEMI cases went down by 50%. So let's say, I'm just giving you a hypothetical number. Let's say we were seeing 10,000 numbers across the country for STEMI. They went down to 5,000. Same thing with non-ischemic myocardial infarction and all cause ER visits. Everything went down. Why? People did not want to come to the hospital and catch COVID. Okay, so I really like this study. I know the slides are busy and it's not very clear, just like the other slides. But what I'm trying to show you here is before COVID, let's say per 100,000 patients, 178 were getting some sort of heart attack, either non-ischemic myocardial infarction or STEMI. The majority of the bulk was non-ST elevation, and some, like let's say 60-40. When COVID happened, the number of cases went down, but the proportion didn't change. So what I'm trying to say is the COVID did not alter the amount of people or proportion of people getting MI or like a ST elevation myocardial infarction and STEMI, but it did drop the absolute number. Again, that goes to show that people are not coming in. Another study, in the same study, but another table shows that now when you say week -1, it's like week away from COVID, week away from like outbreak 3 and 4. So before and after, what they're trying to show. Now when COVID really got recognized, you can see it's like a downtrend. So people are again not coming in to the hospital to get care, and that has a big implication, as you can imagine. Same thing, people were getting stents put in or PCI or therapy, again dropped significantly because not many people were either taken to the cath lab or they were thrombolized and sent home, or they died before they can get caths, etc. If you look at the age, again, there was no change in age. You might say, okay, well, it didn't affect a lot of young people, the mortality of from COVID, and unfortunately, a lot of older people died. Now, this uh, the phenomenon could be driven by the people with age more than 75, but that's not the case. If you look at the risk ratio, it's about the same for all three. So there was a net drop of 34 to 25 to 34% of people based on their age group. Obviously, older the patients, they're less likely to come to the emergency room because they're high risk for catching COVID. So that's very fascinating. Again, this is our study from our own country, California, and what we found is as the number of COVID cases went up, the cases of acute myocardial infarction dropped. Now, this is the orange line or red line is in COVID time, like this year, I mean, versus last year. Now, you say, well, there was not much difference, but here, January area last year, you had 4 per every 100,000 patients. Now you see almost 2. So the rate was almost cut in half. So in California, we observed the same thing. Other data was more European data. This data is US data. So there was a net drop of 48% of acute MI cases. Now, there was a title in one of the European Heart Journal issues, and it says COVID-19 kills at home. Now, this title is a little misleading. When we think of this, it means that people are dying from COVID. That's at least how I perceived it. But what they're trying to say is people are seeking less care that they really needed in terms of ER visits and STEMI and STEMI. The mortality start to rise substantially, dying from home versus a hospital or nursing home, etc. And they took data from 4 different cities of Europe, and they just tried to show the cases of COVID are rising, and out of hospital cardiac arrest were also rising in this, like, just parallelly. So COVID itself is not killing the patients at home, but people are staying because of COVID and they're dying at home. Now, arrhythmia is a little controversial in a sense that COVID directly may or may not cause arrhythmia. I mean, sure, it can cause, but because of systemic illness, people can get PVCs, PACs, AFib. So arrhythmia, I'm going to spend a little time on because data is still evolving. But what they've found is the most common arrhythmia is AFib, followed by non-sustained ventricular tachycardia and bradycardic arrhythmia. Cardiac arrest is also prevalent, but this is, out of 700 patients, 10, like almost 1 or 2% died of cardiac arrest. Now, when you say, so what is the cause of mortality? So the majority of people died from pneumonia or some complications. Those who get cardiac arrest, the survival rate is about 40%. Now, you might see that, AFib. Now, AFib is typically, when you see the patient as an outpatient, we don't associate AFib with such a high mortality, but it is a marker of severity of condition. So that's how I look at it. I mean, cardiac arrest is a whole other beast, but AFib, the way I see it, is a marker of illness rather than significant contributory factor to the mortality. So same thing with bradyarrhythmia, So, I mean, if you have bradyarrhythmia or non-sustained ventricular tachycardia, like PVCs and as such, your mortality is pretty low, or survival rate is pretty good. But AFib is something to keep in mind. So AFib might represent the degree of illness. So myocarditis is a big, big, big topic, and I'll mention some other things that evolved after I made this PowerPoint. So how do we diagnose patients with myocarditis? Well, we can check troponins, but they're not very specific. All it tells you there is something going on in the heart. EKG can be abnormal. There might be some non-specific finding like T-wave inversions, some dynamic changes, heart block, which are manifestation of myocarditis. Echocardiogram is a very useful tool to narrow down the differential, whether this is a pericardial effusion versus there's a regional wall motion abnormalities. that more guides towards MI as opposed to myocarditis. One of the tests that is really picking nowadays is cardiac MRI, which we have that before, and we use it quite often to diagnose myocarditis. But to learn more, and we don't know what's going on with COVID patient, because is it just like another virus, or is this something unique about COVID? The MRI is a very useful test to diagnose myocarditis, and I'll briefly mention some of the indices we use without going into technical detail. The gold standard of diagnosis is endomyocardial biopsy, like heart biopsy, basically. But it could be unnecessary. The risk is high. You can cause damage to the heart structures if you try to do biopsy. So we don't really go to every person who needs diagnosis of myocarditis. We start with MRI. That's our go-to test. Another test we can do is a PET-CT. It's basically like, the oncologists use it to stage cancer. So PET-CT can also show us inflammation, but again, it cannot be very specific. We can diagnose specifically myocarditis, but it can be considered if necessary. So again, this is one case they published from Europe, and I like it because I know it's a lot of things going on, but it tells you a case of myocarditis and all the findings they had. So what they ordered, obviously EKG, they ordered troponins, and they ordered CT to make to diagnose what's going on with their patients in terms of lung pathology. But this was a particular CTA, cardiac CTA, and it showed that there is no obstruction. See how nice looking and clean vessel that this is. So you can rule out any obstructive coronary artery disease. You can order cardiac MRI and look for inflammation, which is hallmark of myocarditis. You can get heart biopsy and diagnose, it's hard to see, but lymphocytes are the blue dots. We don't want to see blue dots in heart because that suggests inflammation. If this was a transplant patient, this could mean acute rejection. So we don't like to see a lot of blues in pink in heart biopsy. What they did is before we knew that hydrochloroquine does not help, they tried this patient on hydrochloroquine and see what happened. Their CRP improved and troponin went down. Now, would you say, like, now they didn't give it from the beginning, they gave it after certain days? Could they have a survival immortal bias, meaning they survived long enough to get hydrochloroquine and they gave him and things got better? If they didn't give him hydrochloroquine, things could have got better anyhow on their own. So we don't know, but this is, again, is subject to interpretation. Now, I talked about MRI. Now, I'm not going to go into technical detail, but I want to just introduce a few terms. Now, you see something called T1 and T2. They help you see how much inflammation and edema there is in the heart. So T2 tells us how much edema there is, and T1 tells you how much inflammation there is. I mean, they can both work together. Now, higher the number, worse it is. So we want some number around 50 and less than 1,000. Now, what they did is they repeat an MRI on this patient, 7 days and 14 days. Now, fortunately, the patient survived and they were able to publish that thing too. Now, look at this number. Day 7, this was 69. It went down to 57. This was, I know it's hard to see, but it's 1209, went down to 1050. So numbers went down, which means the patient is recovering. But still, now this is something called late gadolinium enhancement. This means that it tells you scarring, meaning old injury. Now, when patient underwent the MRI on day 7, there was a little bit of scarring. You see that white thing where the white arrow is, and 14 days later, they had substantial amount. So basically, they still had a residual damage from COVID, meaning they have a now scar tissue. So they tell you that what they're trying to tell you, there are some residual cardiac manifestations of COVID, but this is again very, very short term. I love this study. What they did is they looked at consecutive 39 biopsies, and what they found is very striking. So when you see this brown patch, think of that's COVID genome. So that's their RNA. They stained that. So this is basically SARS-CoV virus, So this is heart biopsy. And what they found is sometimes in some people, they actually have this virus, but it did not cause myocarditis. So remember I told you in the beginning, the virus can damage the heart tissue and cause inflammation. What they found is none of these patients who had virus in their heart had fulminant myocarditis, like a deadly myocarditis. So what does it tell us? Well, they can damage the heart without causing myocarditis. So that's the mechanism number 4, where they can directly cause the injury to the heart muscle. But what they did find is that when they have a virus present inside the heart, those patients had a very high amount of pro-cytokine levels, meaning they have very high inflammation in the body. So is it because of the virus attacking the heart, or just a finding? We don't know yet. Now, these viruses were not just free and floating. They were mostly in macrophages or interstitial cell, right here. So they were not inside the muscle cell. They were outside still. So you don't need virus in the muscle to cause myocarditis, or you don't have myocarditis because you have muscle virus in the muscle. So just try to understand that thing. Sorry, I think, yeah. Now these are very fancy and a little technical, but we can do a very sensitive screen. You might guys have heard about something called strain cardiography. What we do, we look at not just the heart pumping function, but how the tissue of the heart, like a microscopic level, how it moves. And it's very sensitive. For example, we use these, and I do, one of my interest in clinically is cardio-oncology. So I ordered this strain imaging quite frequent. And what does it tell us is before the LV function of the heart goes down, this value can help me see, it just basically you see smoke before you see fire. So that's exactly what it is. So this is more of like a smoke. And if I see something, the patient has abnormal strain, I go ahead and start aggressively monitoring that patient and treat them for potential risk for heart failure. So strain imaging is very easy because if you get an echocardiogram, you can, after you obtain echocardiogram, you can go back and you can apply strain, and the algorithm and program can give you the strain values. What we found is that the patient who have lesser amount of strain values, they have a very high risk of dying or having complication, mortality, basically 2 months later. Same thing, this is RV strain, right ventricular strain. It also had a positive predictive value. So you could have normal echocardiogram, like 50% of the patient had, and still they can have poor outcome if their strain value is low. So what I'm trying to say is, yes, if they have a poor LV function, they are at high risk, but it's not an absolute thing. You can still have a high chance of dying with normal LV function, but if your strain is abnormal. Another fascinating thing for clinician is that now COVID is not the only thing that was found in the patient's, sputum or secretions or bloodstream. Up to 2 to 65% of patient. Now the range is broad, and you say, how do you come up with that range? Because it's a meta-analysis. So they pooled a lot of studies together and they analyzed this patient. So they found that up to 65% of patients can have more than one virus. Now, we know that certain viruses can cause myocarditis and other illness like pneumonia. So do we know what happens when you have more than one infection? Not really. We don't have the outcomes data yet, depending on the co-infection. But actually, we're trying to work on that study right now. I'm actually working on it now. So my idea is, what if you get influenza virus and COVID virus versus either individually? Is your risk of dying is high or not? So, I don't have the data yet, but I'll eventually we hopefully can present to you in form of manuscript. Same thing with bacteria. Now, what happens when you have pneumonia or any infection, you have basically damage to your endothelial cell that protects you in your throat. You can denude that, and you can increase risk of bacteria getting in your bloodstream. So I don't think they're like, just having bacteria, just having COVID causes to other form of bacterial pneumonia, but it predisposes you to, because it can mitigate your immune system, and as such, you're more susceptible to other form of infections. Now, treatment for myocarditis is supportive. What I mean by supportive is like you just watch the patient. If their EF is low, you start treating them with heart failure medications. If they are hemodynamically unstable, we do mechanical circulatory supports like ECMO. And there are some case reports they've used steroids or IVIG, tocilizumab. Now, tocilizumab is it basically antagonizes cytokine production. So basically, in theory, it can mitigate cytokine storms, but we need more data. Another name for it is remdesivir. There's another experimental drug called aldose reductase inhibitor, or known as AT-001. This drug is being studied in diabetic neuropathy. I do not know why they chose to use this in a myocarditis patient, just because theory is to cut down on inflammation. But again, these are all experimental. We don't have the concrete data how to support this patient. Now, heart failure, we hear these terms. It doesn't matter COVID or non-COVID. What is heart failure is an end result of something going on, right, in the heart. So you can have myocarditis, you can have MI, you can have LV dysfunction, you can have arrhythmia, you can have RV failure, or you can have pericardial disease like tamponade or myopericarditis. Everything eventually leads to something called heart failure. And so heart failure is not just its own entity. It's just the way I think of it is as it's a result of something happen of a primary disease. So people with heart failure already have reduced immunity, and they're more susceptible to infection. Generally, people are old and they already have impaired hemodynamics. So if their heart can pump enough blood, imagine they get really sick. How can it pump even more, right? Because the demand is very high. So these people are obviously at high risk for mortality. Now, in heart failure patients, they have a higher level of TNF alpha. As you know, TNF alpha is a pro-inflammatory marker. It's already high in heart failure patients. Now, when you have COVID or cytokine storms, this level goes even higher, suggesting it can cause more damage in already patients who are susceptible to damage. Now, people who were never diagnosed with heart failure before, 25% of them after COVID infection can develop new heart failure. So that's very interesting. There are only case reports on the use of MCS, mechanical circulatory support, like ECMO. So it's not very common that people have very bad heart failure, but they do get heart failure to some degree. And obviously, if you have a poor heart function from the beginning, it can just get worse. Now, I'm not going to go in a lot of detail because that's very focused conversation in itself. I want to give some time to discuss, amongst ourselves. So LVAD patient, patient who have a left ventricular assist device, this is what we use in patient we cannot transplant, but they're still pretty good candidate for the motorized pump, and it can thrombose. So in patients who are prothrombotic because of COVID, this risk is very concerning. So something we have to keep in mind when we see these LVAD patients admitted with COVID. Now, another challenge is, this is a busy slide, but another challenge is heart transplant patients. So people with heart transplant, they already have a lot of medication on board that mitigates their immunity, such as tacrolimus and steroids. When you have COVID, which I guess you need a strong immune system to fight it, it's a tough battle for this patient. And mortality is really, really, really high in these patients, up to 25 to 50%. Now, you might have heard this, and there was a big buzz. So there was one paper published in Nature in beginning of I want to say February or March. Now, the way I showed you the receptor on the cell SARS-CoV-2 virus used to get in our cells is ACE2. Now, what is ACE2 receptor? So we make we know a medication called lisinopril, right, which is ACE inhibitor. It just think of ACE2 as endogenous lisinopril. So what it does, our body makes angiotensin 2, which is a very strong vasoconstrictor. So it increases blood pressure tremendously. When we give lisinopril or body uses ACE2, it breaks this down into less active angiotensin 1 through 7 or 1 through 9, and they are not as potent as angiotensin 2. So what ACE2 does for us is it prevents the high blood pressure basically. So people thought, what if you give ACE inhibitor? Now, when you give ACE inhibitor, you have up regulation of this receptor. So some of the scientists thought that when you give either ACE or ARB, you have more production of ACE2 receptors, you can get more virus. But the problem is, yes, in theory, it could be true, but what happens if you stop giving this medication to people who really need them, especially high blood pressure patients and heart failure patients, you're exposing these patients to strong, potent receptors, strong, potent substances like ACE1, angiotensin 1 and angiotensin 2, and their condition can get worse. So at this time, we do not recommend holding ACE or ARB in patients with COVID unless they have a very bad kidney function or they have AKI. That's a different story, or they're very high potassium. That's a different story. But we do not hold ACE or ARB even in COVID patients. That's the recommendation. Now, again, so COVID is like we just start to learn about these cases. So we don't have a long-term outcome data because we've been just dealing with these for 8 months, which is still feels like ages. What can happen to this patient? Now, again, these are T1 and T2, which you saw from my MRI slide. What we found is this is a very very provoking study from Germany. What they did is they randomly picked 100 patients with COVID, not hospitalized. It could be community patients, outpatients. They just said, we want you to get we want you to get scanned. And what they found is that up to 78% of patients had some degree of cardiac involvement, which is very high. And again, this is not hospitalized patients. These are all comers, randomly selected patients. Up to 60% of the patients had inflammation after 71 days, which means even after 2 months since they were diagnosed with COVID, they had an active inflammation. Now, this becomes a very important issue, specifically high-risk population like athletes. We know athletes can have high, so previously we know that athletes who have sudden cardiac death on the field, 25% of them had myocarditis on autopsy. Now here, you already have myocarditis, and you let them play or not play. So this is a subject of ongoing debate. We don't have the data, we don't have the study, we don't have strong recommendation on what to do with these patients, but I'm just throwing it out there. If you have athletes, think twice before you just saying go ahead and play sports. Think, evaluate, order biomarkers, order echocardiography. If something comes back abnormal, you might consider cardiac MRI. So letting you just to let you know, because you might be seeing these patients as an outpatient for clearance. Now, I'm just gonna, in last few minutes, I'm just gonna go over some of the therapies and how they are linked to heart disease or what kind of side effects they can cause. So lopinavir and ritonavir combination was used because these are antiretroviral therapy for HIV patients, but they thought because they work on RNAs, RNA polymerase, we can use this and see if we can treat COVID with this. Unfortunately, it did not pan out, but it can cause bradyarrhythmia. Now, recovery trial is a recovery group from UK or Europe. They came out with 3 major trials. Now, they're the ones who showed that hydrochloroquine does not have any mortality benefit. Now, generally, there was a big buzz. Hydrochloroquine can cause ventricular arrhythmia. It is still true, but hydrochloroquine is a very ancient drug. We use that for rheumatoid arthritis and a lot of inflammatory conditions. So it's a well-established drug, no question about it. But when you combine this drug with other QT prolonging medication like azithromycin or some antidepressant, you better start monitoring their EKGs. In this particular study, they did not have a higher risk of ventricular arrhythmia than the control group. So here it did not pan out. There was no mortality benefit. Now, dexamethasone has so far has proven to be medication that can help us with some mortality benefit. For example, when they give dexamethasone to patients who are intubated, they had much better 28-day all-cause mortality, 21.6 versus 24.6 in placebo group. We don't know any direct side effects, but we don't like to use dexamethasone in heart failure patients because it can cause fluid retention, but this is a different story. We really need to give them to help them survive. But I'm just saying, as you know, we don't generally put people on steroids and let them go without monitoring their fluid status, right? Now, I just made a table for you guys to quickly look at it. I know there are a lot of drugs, and many of them we may not directly use them, but majority of the anti-SARS-CoV therapies have some degree of arrhythmia issues, but fortunately rare. Now, one of the things we need to be wary of is when you see patient hydrochloroquine and azithromycin. I'm not saying because of COVID, patient can have rheumatoid arthritis and they can have bronchitis. We could be prescribing this medication. Just monitor their EKG. So don't just give this medication and let them be. Check before and after to make sure that they don't already have prolonged QT. Okay. In summary, patients with cardiovascular disease are at high risk for COVID-related complications. It can cause new cardiovascular diseases in COVID patients, up to 25% of them. We're still learning about how COVID can affect, or SARS-CoV can affect the cardiovascular system. We know some preliminary data, but I think more will come as time passes. CT, MRI, and cardiac CT and cardiac MRI can be useful to establish diagnosis and prognosticate. And we shall wait for long-term data for what's the prognosis and what happens, what's the implication of COVID on cardiovascular health. And I'll take questions.
Thank you so much, Dr. Patel. That was all really interesting and super timely didactic, to say the least. So we appreciate it very much. So we have about 5 minutes left. We wanted to open it up for any questions for Dr. Patel, comments or thoughts.
Dr. Patel, this is Dr. Paliwal. In my primary care practice, we clear mainly school students for the sports physical.
Mm-hmm.
Okay. I know you mentioned about to pay special attention to it. Now, is there anything like we need to do an EKG or anything if they are asymptomatic, or we?
No, excellent question. So yeah, it applies to any sportsman, right? So elite athletes to college footballers. So right now, yes, I think EKG, you can start with biomarkers like troponin and BNP, and sometimes some people use CRP just to see if they have active inflammation, but not on every patient. I'm talking about patients with positive COVID. Now, if you're asking me general question on any athlete, it depends on their family history. So if they have history of premature coronary artery disease or sudden cardiac death, I would definitely get EKG on an athlete as a baseline. But you don't need EKG on every single all comers. But obviously, if you have a COVID positive patients, I would pay more attention to screening process. We don't have the data or established protocol even from American College of Cardiology yet. But what we do in case, let's say they have a COVID positive, obviously you're going to quarantine them for 14 days, and you repeat these biomarkers. And if there's positive biomarkers, you refrain from playing sports until you get more testing, like MRI. Hypothetically, if cardiac MRI comes back positive, they should be refrain from playing sports for 3 to 6 months until we know definitive evidence that the inflammation has gone. Now, this is a general rule for all patients, but I'm not sure are you asking me specific to COVID positive patients or?
Yes, when you say COVID positive, it can be two things, like they have COVID right now, or they had COVID infection in the past. So,
Yes.
so it
Yes.
applies to both, right? Of course,
Yes.
if they have active COVID infection right now, we're not gonna clear them.
Yeah, exactly. Your point is right. So obviously, if they are COVID positive, wait. But at some point, when before you cleared them for sports, you need to check their heart. So baseline echo, EKG in the clinic, echo, local facility, and biomarkers. I think that's a good screening tool, but this is my personal recommendation. But if you are not sure, you can send it to, for example, local cardiologist to us for further like evaluation.
Okay, thank you.
Excellent. Any other comments, questions? All right. Well, I don't want to hold you guys any longer. I'll give you guys 2 minutes back to your day, but thank you so much for the wonderful presentation. We got a big thank you for the excellent presentation in the chat as well. So we really appreciate it, Dr. Patel. So just one quick housekeeping announcement. Our next session will be on September 4th, and Tricia Petit is providing the didactic on case studies and presentations. So keep an eye out for that reminder. I will be attaching Dr. Patel's didactic from today into the recap email, so also keep an eye out for that. And we'll see you guys next time. Thank you so much.
Thank you for organizing it.
Thank you. Bye-bye.
Thank you.